At this year's Congress, there's basically two highlights. One is precision medicine, and the other one is the Healthy Lungs for Life campaign. The Healthy Lungs for Life campaign, breathing clean air, I mean, particularly important for London, obviously. We've started with the ERS when the Congress was in Munich 2 years ago, and ever since it has continued to involve all stakeholders and the general public in a campaign that raises awareness for lung disease and clean air, basically. So that is one of the highlights, I think, that has evolved superbly with ERS in the past years, and this year with the highlight of lung function testing at Trafalgar Square and the associated symposia, I think is just a winner. The second scientific topic, clinical scientific topic that I think will dominate the next year is precision medicine. So I think in most of the chronic lung diseases that we have at the Congress, there are specific symposia dedicated to how we treat patients better and more effectively in years to come. Applies to asthma, applies to interstitial lung disease, applies a little bit to COPD, although not that well developed currently, and pulmonary hypertension specifically. My own area of interest is interstitial lung disease, so a lot has happened in the past 10 years, and that's then a disease that where actually many symposia are dedicated to the new approved therapies, bifenthrin and nintedanib, but also therapies that are probably on the market in the next decade, I would say. Well, you know, as of today, if you look at, for example, the 10 biggest grossing drugs in the US, Advair is one of them, and being for lung disease. For every patient you treat that gets better, you know, somewhere between 4 and 25 patients don't have an effect, and that's clearly inefficient. So I think in all of the diseases that we are faced with in our daily life, we need to get better. So we need to know exactly when a treatment actually affects a patient to the better and when not, and when a side effect outweighs the treatment effect and when not. And I think that is the big challenge for all of us, scientists, physicians, physician scientists alike, patients as well, to basically get better in diagnosing, monitoring, and treating. Well, I'm likely a very bad example to be asked that question because I'm very unorganized. But I would say if you go to ERS, if you are somebody that is new to the scene, and this is, you know, the first, second, third Congress you go to, you have to be organized because the conference has grown so incredibly large now. I mean, we have in London like above 22,000 people registered for the conference and participants. So there are a myriad of symposia that are actually concurrently at the same time. So just by going and choosing on a random basis won't really do it, I think, due to the size of the conference. But if you plan well ahead, we've basically grouped the conference into certain tracks. So you have tracks, for example, specialty tracks as well, basic science core, asthma tracks, COPD tracks. I think then you can plan your day incredibly well in that I would say within 2 days, you cover a whole disease and you get up to date with all the newest developments in sessions such as the scientific or clinical year in review, and you're up to speed with all the developments in at least 2 days. But surely enough, you can even cover more diseases on the 5 days of the conference. So it's a huge organization. It has grown incredibly large. It's the largest respiratory congress in the world. So if you plan it well, I think you can take a lot home from this conference. Well, I'd say ERS has, you know, 3 pillars. I mean, we have the education pillar, we have advocacy pillar, and we have clinical pillars. And I think all of these pillars basically join together in creating, you know, an incredibly valuable resource for the whole clinical community around the world. For example, on Saturday we had specific sessions dedicated to China. We had sessions in French. We had before Russian sessions. We had Spanish sessions. So ERS, I think, is superbly well organized in that it outreaches to all of the communities in the world. And if you, for example, dedicate a session such as a clinical year in review, summarizing the current guidelines, for example, to the whole world, it has tremendous clinical impact because you affect every treating physician in a whole area, in multiple languages actually, so that worked very well in the past years, and well, we're continuing that in future years, obviously. Well, I love it because you can direct a discussion if you want. I mean, first of all, it's an incredible honor to be on the same podium with some of the speakers that we, have at this conference. Some of very distinguished scientists, physicians alike. And it's good to be on the same stage. And usually in a symposium, you combine, 4 to 6 speakers that talk around one specific topic. And as a chair, you can basically guide the discussion in directions that you like and that you deem are interesting for the audience. In large symposia, and I mean here we sometimes have symposia with 2,000 people in the audience. Sometimes nobody really stands up and asks a question for whatever reason. It's just trade of the game. But in those sessions, the chairs usually ask it's privilege of the chairs to ask the first questions, and that's how you then guide a direction of discussion. And usually what happens after the chairs ask the one or second question, then the audience, slowly warms up, and then you get a discussion going, and that's very rewarding, actually. So my home base sort of is interstitial lung disease. I've been working with interstitial lung disease, specifically idiopathic pulmonary fibrosis, for, I would say, by now 20 years around, so pretty long time. And we have multiple presentations on this topic. Myself, as well as members of the Institute and/or lab, have presented here on interstitial lung disease in large symposia, such as the Scientific Year in Review, which is packed. The IPF sessions are usually packed at the conference. I mean, there's standing room only, and many times people don't really get into the room anymore after the first talk is going on. And then you have junior members of the Institute and lab, which are presenting in poster discussions and poster sessions. So basically, a whole group engages around one topic, which is a very rewarding experience also for the junior members. Well, because we don't know how the disease develops, despite the fact that we have 2 approved therapies right now. We don't know what the natural history of the disease really, which route it takes, where it originates from. For the longest time, we didn't even know a very good risk factor for IPF. Now that has changed in the past, I would say 3 to 4 years, in that we now have genetic risk factors that at least can explain 30% of IPF. But before, that was not the case. So nobody really knew how such a terrifying disease, which has a median survival of about somewhere between 2 to 3 years still. So an awful disease, awful quality of life, terrible fate for our patients. Where it comes from, how we could possibly detect it early, how we can monitor progression of the disease. There was nothing known about the disease for the longest time. So that is fascinating. I mean, besides having this tremendous effect on our patients, scientifically, to me it's fascinating to try to explain something that doesn't have an obvious reason when it happens. COPD, lung cancer, we have a risk factor, smoking. So stop smoking and you probably get rid of a large proportion of lung cancer and/or COPD. That's not the case for IPF. These patients have not smoked, most of them, ever. But they get a terrible disease that ultimately kills them, and that's a huge motivation. Well, the best known risk factor right now, around 30%, is polymorphism in a gene that's a mucin gene, so MUC5B. Mucins are usually molecules that are secreted into our airways and then clear pathogens, particles from the airways by transport to the oropharyngeal space. That was discovered around 5 years ago. So this is the risk factor we are now dealing with. However, we don't still fully know how that genotype leads to onset and progression of the disease. So while we now have identified a risk factor, which has been superb progress in the field, we are now at the stage of trying to explain how a certain genotype then leads to disease. So this, genotype-phenotype correlations and how they interface with each other and how we can probably prevent it. The first ATS ERS consensus statements on IPF, on classification of idiopathic interstitial pneumonias, and now on treatment of IPF, really are not a lot older than like 10 years. So I think at the beginning of the millennium, we got together and basically had consensus conferences. And then with the advent of there was no real effective treatment until nintedanib and pirfenidone were on the market. Pirfenidone a little bit earlier in Europe and a little bit earlier than nintedanib, and then also in the US afterwards. So really until those trials and until those approvals were actually granted, we had no effective treatment, not even for a single person, basically. So that has really changed the field. As of now, you have in most centers that are expert centers for IPF, you have multidisciplinary consensus conferences to have a clear-cut diagnosis of the disease, and then also guideline rendered treatment of IPF patients. So obviously microbiome, i.e. the colonization of bacteria or microorganisms of our body, in particular the lung in the case of the ERS conference now, is one of the scientific highlights of the past years. I mean, that was an area that was, if you'd ask people, I'd say, well, 5 to 10 years ago, everybody would have said, well, the lung is sterile. There's no bacterium in the lung at all, full stop. That has changed. It is still a controversial topic. You will have people that say there is no clear-cut evidence in the human distal lung of bacterial colonization. But there's a lot of research that has emerged in many diseases and in the normal lung that indeed there is colonization. So changed microbiota in our terms. And that really is an area that has evolved not just in lung research, but in other areas such as inflammatory bowel disease and dermatology tremendously in the past years. So in and by itself, it's its own field of research now, microbiome research. And as such, the conference committee has highlighted or has chosen to highlight this symposium or these symposia at this year's conference. So yes, you're right, on Tuesday I'm chairing the major symposium on microbiota and health and disease, and I sure hope it's going to be a fascinating session. Well, there's very good evidence that changed colonization of organs, such in this case as in the lung, really A, leads to onset of disease, B, modifies disease progression, and C, determines disease outcomes. So the lung is a little bit behind other organs, such as, for example, inflammatory bowel disease or bowel in general. But we have to do the homework now. We have to see how that influences also treatment responses. In certain cases, changed microbiota will render certain drugs ineffective. And that is a huge area of research there where I think there's a lot of careers in that field to be made. Well, I think disparity in standards of respiratory care or also in standards of healthcare in general is a huge problem in Europe. I mean, the ERS has addressed that specifically for a couple of years now by addressing health inequality across Europe. And I think that's an important area of research because not everywhere in Europe a patient with a definitive disease gets the same standard of care. Now, obviously, it's also a financial question and it's also a political question in terms of how or what standard a society allows its inhabitants to profit from in terms of healthcare. But we've addressed that. So there clearly is health inequality, not only just in Europe, obviously in the world as well. Many respiratory societies, also the American Thoracic Society, have addressed that. But there's a lot to be done because, again, it depends on the political system and on the healthcare system of a country. I would probably say that Germany is one of the more luckier nations, along with France and the UK, in terms of what they can offer their citizens in terms of healthcare. But there are other countries which have a long way to go. But it will require a lot of investment in terms of dedicated personnel and also money, obviously.